Bob.
Thank you very much. I appreciate the opportunity to speak in front of this group. Again, I guess I'm the second cardiologist of the day that's gotten the opportunity to speak to you. So we're going to talk about PDE-5 inhibitors. Could they be cardioprotective? My disclosures are listed here. This really started with a couple studies that were done in the past, one by D'Souza, showing that oral sildenafil improved flow-mediated vasodilatation in the brachial artery in men with type 2 diabetes and with ED. And therapy both acutely and chronically improved flow-mediated vasodilatation. And the effect lasted for at least 24 hours after the last dose. Then Rossano et al. Explored patients who had increased cardiac risk who received either tadalafil, 20 milligrams, on alternate days or placebo for 4 weeks. Tadalafil improved flow-mediated vasodilatation of the brachial artery, and the benefit was sustained at 6 weeks. Now, this slide shows that there have been really a number of studies reported in the past looking at men with ED, primarily in subgroups of men with diabetes, coronary artery disease, or rheumatic arthritis, who received PDE-5 inhibitors versus those who did not. And those that received PDE-5 inhibitors in general had lower rates of adverse cardiovascular events. Now, let's see, this went backwards. Let's see. Okay. Now, our group looked at the effect of PDE-5 inhibitors on major adverse cardiovascular events and mortality in a large commercially available insurance database. So we looked at men who had ED, who had no history of previous major adverse cardiovascular events, and observed those who were on PDE-5 inhibitors versus not on PDE-5 inhibitors. And this was a retrospective observational study published in the Journal of Sexual Medicine in 2023, the effect of PDE-5 inhibitors on major adverse cardiovascular events and mortality. So we started out with a study cohort of men with ED during the study period, looking at men who had claims for PDE-5 inhibitors versus no claims for PDE-5 inhibitors, and then met enrollment criteria, which included no history of major adverse cardiovascular events in the year prior to entry, and then we matched those on baseline cardiovascular risk factors as well as cardiovascular medicines. So there was 23,816 in the group of men with ED who received PDE-5 inhibitors and 48,682 who did not receive PDE-5 inhibitors. The major study endpoints included MACE, which is major adverse cardiovascular events. This includes a composite of cardiovascular death, hospitalization for myocardial infarction, coronary revascularization, which includes percutaneous coronary intervention or coronary artery bypass grafting, stroke, heart failure, unstable angina. We also looked at overall mortality, that is mortality due to any cause, which was acquired via the National Death Index. There were 4 basic objectives: to measure the associations between the use of PDE-5 inhibitors in men with ED and MACE and mortality. Objective 1 was to look at men among commercially insured with ED without evidence of MACE in the 12 months prior to entry into the study. Objective 2 was to look at among men with ED and no coronary artery disease, but with known cardiovascular risk factors such as hypertension, dyslipidemia, diabetes, smoking. Objective 3 was to look among men with ED by the level of exposure to PDE-5 inhibitors, the number of pills they received, the highest quartile, the 4th quartile being the most pills, and quartile 1 being the lowest number of pills. And objective 4, among men with ED and type 2 diabetes or coronary artery disease. Now I'll show you a series of forest plots. For those not familiar with forest plots, where the dot and the horizontal line are, if they fall to the left of unity and do not cross that line of unity, it's statistically significant in favor of PDE-5 exposure. So if we look at objective 1, among men with ED without previous evidence of MACE, compared to men unexposed to PDE-5 inhibitors, 48,682, after adjusting for baseline characteristics, those who were exposed to PDE-5 inhibitors, 23,816, had a 13% lower rate of major adverse cardiovascular events. In addition, they had a 60% lower rate of myocardial infarction, a 60% lower rate of coronary revascularization, lower rates of heart failure, lower rates of unstable angina, and a 39% lower rate of cardiovascular-related mortality. Overall mortality was lower by 25% in those on PDE-5 inhibitors. This slide looks at the Kaplan-Meier curves, and here we see the unexposed is shown in red, and the blue is shown is the exposed, showing that survival, that is adjusted survival for those looking at MACE, that MACE was lower in those who were treated, and overall mortality was improved in those on PDE-5 inhibitors. This looks at objective 2. Among men with ED and no coronary disease, but with cardiovascular risk factors, findings were similar. There was a 12% lower rate of overall MACE, and there was a 24% lower rate of overall mortality in those exposed to PDE-5 inhibitors. Objective 3 looks at men with ED by level of exposure. The first quartile is the lowest level, and the fourth quartile is the highest level of exposure. And we observed that after adjusting for baseline characteristics compared to men with the lowest level of PDE-5 exposure, those with the highest level of exposure had a MACE rate 55% lower for those on the highest dose versus lowest dose. And there were significant reductions in myocardial infarction, coronary revascularization, stroke, heart failure, unstable angina, and cardiovascular-related mortality in those on the highest levels versus the lowest levels of exposure. And mortality was 49% lower in those on the highest doses. Here are the Kaplan-Meier curves showing this data. Again, those on the highest doses had the best survivals for both MACE as well as overall mortality. Now, among men with ED and type 2 diabetes, there was a limited precision due to smaller sample size and lower number of events, but compared to men unexposed to PDE-5 inhibitors after adjusting for baseline characteristics, those exposed to PDE-5 inhibitors had 21% lower rate of overall MACE. However, there was no statistically significant reduction in rates of individual MACE components, although trends in the right direction, and there was no statistically significant difference in the rate of overall mortality. In men with coronary artery disease, there were also lower N values, and we did not observe significant differences in MACE or mortality in those on PDE-5 inhibitors versus not on PDE-5 inhibitors. Now, recently, we also reported in the same general cohort of men with ED, data on those exposed to the long-acting PDE-5 inhibitor tadalafil, comparing men with ED exposed to tadalafil versus those not on tadalafil. And the data are shown here on the forest plots. If we look at the general cohort of men with ED, There was a 19% lower rate of MACE in those on tadalafil versus those not on tadalafil or PDE-5 inhibitors, a 31% lower rate of revascularization, a 45% lower rate of unstable angina, a 55% lower rate of CV risk, a 44% lower rate of all-cause death. And if we looked at objective 2, which is men with coronary disease, without coronary disease but cardiovascular risk factors, we found similar results. This shows forest plots, and those on the higher doses of tadalafil, the 4th quartile, versus the lowest dose, the 1st quartile. And again, we saw similar results when we compared to our previous study looking at doses. Those who were on the highest quartile had the best outcomes, and this was true for overall MACE, myocardial infarction, coronary revascularization, stroke, heart failure, unstable angina, and cardiovascular death. Here's the Kaplan-Meier curves looking at tadalafil exposed versus unexposed. On the left is adjusted survival curves for overall MACE, showing those exposed to tadalafil, shown in orange, had a better survival than those unexposed, shown in gray. And on the right are shown the data for overall mortality, again favoring tadalafil. And then again, here is the data on doses. The 1st quartile is shown in gray, and the 4th quartile, the highest doses, are shown in orange. Again, those in the highest doses of the drug did better in terms of both MACE as well as overall mortality. So what are some of the potential mechanisms of PDE-5 inhibitors by which they might protect the effects on the cardiovascular system? This may include, number 1, improvement in endothelial function, as I showed you on the first few slides. 2, vasodilatation with small reductions in blood pressure and reduced afterload. Direct cardioprotective effect on the ischemic reperfused myocardium is shown in some preclinical studies. A potential anti-inflammatory effect, antiplatelet effect. But there are limitations to these studies. Because of the retrospective design, there could be residual confounding, inability to establish causation, because this is retrospective, not a prospective study. But the dose response data is promising. A prospective randomized control study is desperately required to determine causation. PDE-5 inhibitor exposure measured via tablets dispensed. Adherence was not assessed, another limitation. And PDE-5 inhibitors and aspirin could have been obtained outside of the insurance benefit, which would not have been detected. So in conclusion, among men who took PDE-5 inhibitor medications in our first study, the risk of major adverse cardiac events was 13% lower than those not exposed. The rate was even lower for death from heart disease, by 39% lower, unstable angina, 22% lower, heart failure, 17% lower, and revascularization procedures, 15% lower. Finally, I'd like to thank my colleagues who were involved in this study, including the investigators from Health Corps, including Eric Stanek and his associates, Dr. Ray Rosen from UCSF, and Julia Bradsher from HMRI. Thank you very much for your attention.